see. Well, good morning, everyone. And she said, I'm going to be talking about fatigue. So I thought, since we're in the morning here, some of us have had a lot of long days so far, or starting long days. Here's your complimentary fatigue buster to get you going for my talk and to keep you up with what I'm saying. So we always need to start our day as academics or in this field with a quiz. But I decided I'd make this a really easy quiz, given what the title of my talk is. But I really wanted to point out that over the course of a cancer patient's journey, what is by far the most common problem? Is it fatigue? I mean, is it pain? No. Is it depression, anxiety, and stress, other mood disorders? No. Is it nausea, vomiting, GI issues, loss of appetite? No. Well, guess what? It's fatigue. So all different types of cancer across all different stages of diagnosis, all different types of treatments, all of them both have fatigue during treatment and after treatment. And more research is showing this. These are just averages. Some types of cancers have much higher levels, both while undergoing treatment and during treatment. So I talk to a lot of oncologists, and when I talk to them about fatigue, one of the first things they say to me is, well, I'm tired too. Yeah. And I say, okay, I appreciate that. All of us have that. I just want to emphasize that here in this graphic, what this is showing is for cancer patients, you have normal fatigue at the baseline. All of us have that. And then you have on top of that, that tired you get on a Friday afternoon, right, at the end of the workday. Then we have other health problems, which cancer patients have as well, like diabetes, heart disease. They have that on top too. Then if they're going through treatments, or they may have the late-term effects of other harsh treatments, the stress of the cancer biology itself, the travel to treatments, and then on top of all that is cancer fatigue, which some people even say, I'm so tired, I can't even sleep, I'm so tired, to get to actual in bed. So it can be very, very debilitating. Sometimes they say it lasts longer than other types of fatigue, and even though they sleep, it's non-restorative. And here it says, my brain says go, my body says no. I don't know, I hope none of you felt that too much this morning. They also talk about it's a whole body experience here, all over, in quicksand, exhaustion, inadequate energy. So, not surprising, fatigue impacts all levels of a patient's quality of life and social functioning, from their job performance to interactions with families and friends, to depression, to chronic pain, obviously to sleep problems. When you actually treat the fatigue, you get a great bang for your buck because in all senses, you end up treating these other things as well. Sometimes, when you treat these other things, such as depression or chronic pain, you often don't get at fatigue. So fatigue seems to maybe be a higher level downstream symptom to some of these others, okay? So another thing that's been emerging in the last few years is fatigue as a risk factor of reduced survival. And I think this is very intriguing and important. You can see here both as a predictor of recurrence and overall survival, and it gives an independent prognostic factor that goes above and beyond biological factors that we often use in our prognostic models with patients. Now, this isn't just in one group either, and this is not comprehensive, but I'm just going to show you here. It's been seen, so these are subjective pen and paper reports of fatigue and/or salivary cortisol over the course of 24 hours. So people have looked at both measures in breast cancer survivals, recurrent high-grade gliomas, esophageal cancer, prostate cancer, myoplastic syndromes, and metastatic colon cancer. The list could go on. So how do we treat fatigue if it's so important? We have actually very few good treatments for fatigue. And I'll say we have pharmacological treatments. There's very little evidence actually that they actually treat fatigue and treat it well, and often have unwanted side effects. Now we have exercise, which I'm going to say has level 1, both during treatment and after treatment in survivors. We'd love to have patients do it. I'm going to talk a little bit more about how acupuncture and acupressure may impact that. We also have some great psychological and behavioral treatments. However, we have some issues still with stigma, Obviously, insurance, both a lack of insurance and underinsurance, and availability of practitioners, particularly, as you can imagine, in rural areas or in certain urban areas in particular, but not just. So I pull up this graphic here. This was actually a survey in disabilities, but it roughly also is exactly the same in cancer patients and survivors. And what I want you to see there is the second to last yellow bar, 43%, is lack of energy or fatigue is a barrier to exercise. And also lack of motivation is 41% there. And we also have exercise program costs. So if this is our level 1 way that we actually want to get people to treat fatigue, it's the #1 barrier that people use to not start or maintain exercise. So what I propose is for acupuncture or acupressure, you can do your 6 to 8 weeks of treatment, right, to help with the fatigue that might help to actually remove some of that barrier by treating it, and then they can go on to exercise. So it's really a complementary way of looking at things. You also have self-care things. I'll be talking more about self-administered acupressure, and there's also been a study looking at self-needling and acupuncture for fatigue. And both of those could be things that if people had program cost issues, then they could actually do these other treatments. So I put it up there. Yes, that's a silly cat. I'm sorry. There has been 14 so far randomized clinical trials with acupuncture and or acupressure, because sometimes they put them together for fatigue. Okay? And I made this slide here just to give you an idea of the cancer types they've been done in. You can see lung, leukemia, ovarian, breast, and adult mixed cancers, and whether or not they were during active treatment, post-treatment, or palliative care. So you can, what I really want to point out here is this is a highly heterogeneous group of people. Cancer, as we know, is not just cancer, and it's all across the cancer arc. So just to keep this in mind when we talk about some of the evidence. So here's a busy slide. I apologize for this, but this is drilling down into the cancer trials during treatment. So I want you to keep in mind that fatigue and causes of fatigue during treatment are likely quite distinct from post-treatment because you have a lot of cell necrosis and potentially inflammation from the chemotherapy, radiation, surgery, etc. And so what I really wanted to bring home for this, and you can see here we have quite a range of cancer types as well. Here are results. Positive means it was positive against either usual care or sham control, and negative means it was not. And you can see some of them looked at through time, through treatment. And what I really want to show here is if you look at usual care, right, you see it's positive. It was significantly better at reducing the severity of fatigue. When you look at sham, acupressure or acupuncture, what you see is you begin to get a little bump, but then it goes down as the fatigue worsens during treatment, and there's not a significant difference. Even though both for the sham and for the true acupuncture, you do see a significant decrease, but they're not different from each other. Well, what does that look like for trials of post-cancer treatment? So you can see here that we have a lot of breast cancer treatment trials, some of them quite large, of several hundred people, and we have mixed adults. And when we look at the results section again, you see very similar pattern happening. So once again, when you have it against like a waitlist control or usual care in general, and I'll say some of these are complicated trials because they are equivalency trials, but what you basically see is that yes, you have a significant difference against usual care for decreasing fatigue severity, but when you put it against sham or you put it against a similar type of placebo, you don't see as good a result. So what can you conclude overall from these clinical trials? Well, on average, you see a severity reduction of about 30% to 40%, which is pretty good. It's actually clinically significant. There's very few side effects, which is great, but we have small effect sizes when compared to sham, but significant when compared to usual care, which is really great if all you have is usual care. But as we know, oncologists in particular, they really like to see a difference from sham. But I'd like to put forward some ideas of how we might want to think about this in the future, both as researchers and clinicians. So the first thing, which is not new to those of you in the acupuncture and acupressure fields, is sham acupuncture and acupressure an active intervention? And how might we think about that? So this was a study that was done in 302, I think, right around there, breast cancer patients. It was a pragmatic RCT comparing usual care to acupuncture that was done for 6 weeks. And that was done with the MFI, which is the Multiple Fatigue Inventory, a measure of fatigue. These were the mean change over the weeks. And that was the black dotted line. The blue dotted line are just the deviations, the variations in the study. And you can see that clearly the acupuncture group there on the top, the mean, had a greater change and improvement, because going down on the MFI is good, than the control group. So this was really great. This got into, as you can see, Journal of Clinical Oncology, a very high-level journal. They were very happy with this. Here we had one with Dr. Judith Balk, now where you had Sham, and you have the two overlapping. Now I want you to realize that they were significantly different at baseline, so you need to look at the change and realize that the change through time was the same. And so here we had a Sham acupuncture. The Sham points were at the same points. So this is similar to what you see in a lot of clinical pain studies. Once again, that you're seeing quite a lot of treatment effect from Sham needles. So what can we conclude about some of these Sham treatments? Well, we actually, as researchers, need to know what are the active components of the acupuncture and the acupressure. Is it somatosensory? In other words, is it the amount and time of touch that we're actually feeling? Is it the self-care component that a patient gives to themselves, whether it's to come in to see a provider or to do it for themselves? Patient-physician interaction. Time and attention to actually take care of yourself. Or something that's been really intriguing myself and my colleagues, are point specificity. Could there be issues with point specificity? So I made this heat map. This is a heat map of points that have been used, acupuncture and or acupressure points, in the 14 randomized clinical trial. Now there were some of them that did totally individualized, but I believe that was only 2. And so what I wanted to see is, did it make a difference? And I apologize for those of you who do acupuncture, acupressure. These are huge points. These cover many points. But I figured I wanted you to see them in the back of the room. Yes. And so basically, for those of you who aren't acupuncture, acupressure practitioners, these would be much smaller. And the little lines there with the words like HT6 means heart 6. So that's what we would call these acupuncture, acupressure points. So what you see there is the red there, the red ones mean like 10 studies, 10 of the RCTs use this point. All right? In orange, 6 of the studies use this point, down to the dark blue, where only 1 study used this point. Now, in all fairness, if the same group of people, so the same authors, were just building on their other studies, I condensed them into one, so it didn't get repeated. So I thought that was fair. You can tell me if you think so. So let's go back to the Judith Balk study, where we had the 2 coming together. Here are the points that their group used. You can see that they are very common points. They're red, yellow. We have one light blue that kind of fell in the middle. But overall, these were very common across the studies. And you did see about a 30 to 35% decrease in the severity of fatigue through time using the FACIT, which is another fatigue scale. And by the way, in that case, going up is better. I'm going to compare this to a study that myself and Dr. Rick Harris did together. This was in adult cancer patients, and we actually looked at 2 different formulas of acupressure, looking at the brief fatigue inventory. And this is looking at them through time over 12 weeks. People did them for themselves, self-administered acupressure, once a day in the one of the groups. So what I'm going to tell you here is RA is for relaxation acupressure. That's the red. The black are 2 doses of stimulating acupressure, H for high dose and L for low dose, so His and Lis. And basically what we found is that you had about a 30 to 40% reduction, as we've been talking about, from the His and Lis, and we had a 70% reduction in the relaxation acupressure arm. So they were significantly different from each other. So what was our point? So for the His and Lis, which were the same, just at a high dose and a low dose, we were using almost the exact same points as you saw in many of the other studies, in the Judith Balk studies, okay? And so we thought these were going to be the take-home points, by the way, when we did this study. And that's why we do research. Here were our relaxation acupressure points. You'll see there that with the exception of one point, they were all blue, dark blue. In other words, we were the only ones who had ever used them in a fatigue study. So this is where you got a 70% mean reduction across all these different participants, all right? So we said, that's interesting. So we kind of took a sideways step and we said, well, to understand what might be going on here, what causes cancer-related fatigue? And I give you this little cartoon here. I'm not kidding. It's very, very multifactorial. You have all the treatments that people are going through, the cancer biology, you have the comorbidities, you have poor diets, you have poor sleep. The list goes on, and this is not comprehensive. But the underlying mechanisms, of why these cause fatigue, not so much information. So we've known from a long body of research that various types of inflammatory markers in the serum, so circulating systemically, are increased in both cancer patients, which may not be surprising, but also in cancer survivors. Now, most of those are association studies. So they compare them to non-fatigued cancer survivors, or they compare them to people of their same age and sex in the general population. And these inflammatory markers, such as IL-6, TNF-alpha, et cetera, are higher on average, as well as SNPs and cytokine genes, as shown here. And they've been proposed that they lead to fatigue. Now, these are not highly elevated, especially in post-treatment. They're actually very lowly elevated. As a matter of fact, sometimes it's hard to see with some of the assays that we have. So people have proposed a model. I want to say this is not the only model, but it's one of the leading models of cytokine-induced sickness behavior, which may be familiar, especially if any of you are depression researchers, actually. And the thought is that when you have this cascade of inflammatory cytokines there that you can see, the IL-6 to TNF-alpha, the IL-1 beta, they cross the blood-brain barrier, they go into the brain, they actually activate an inflammatory cascade, okay, and then they change neurotransmitter levels, which then lead to changes in behavior, which include fatigue, all right? And that this is actually maintained long-term at a low level through time, instead of being resolved like it would in an infection. However, guess what? No one had ever looked to see if those higher levels of inflammatory cytokines led to any changes in the brain. So we know that you have to change things in the brain to change behavior. If you take the brain out, you don't have behavior. We often say this to people who are saying, well, what about tissue level things? And we say, well, yeah, it's the brain. When you look at fatigue. So what we did is that we looked at 30 fatigued and non-fatigued breast cancer survivors. We matched them for age, so like a 15-15 there. And we just wanted to look at their levels of circulating cytokines in the serum. And we also wanted to look at levels of neurotransmitters in the brain. In this case, the excitatory neurotransmitter, glutamate and glutamine, you look at the two of them together, and also another one, creatine to total creatine. So we wanted to look at them and we wanted to see how they interrelated. So the first thing I wanted to show you, these are the things that came out significantly different between the two groups, all right? So you have the glutamate and the glutamine, higher glutamate and glutamine in the posterior insula, all right? These were all in the posterior insula in the brain. We looked at other areas of the brain, only the posterior insula. So for those of you who don't do neuroimaging or who are not neuroscientists, I assume there's a few of you out there. Yep. So the posterior insula is well developed in primates, and particularly in humans, and it's involved in the kinesthetic sense of our world. So we kind of take outside things, the way we touch, the way we feel, and we interpret them into kind of emotional and mental constructs. So you can see how maybe a feeling of fatigue, either mentally or emotionally, could be actually perceived in the insula. So in the insula, higher glutamate, higher excitation. We know that's also associated with increased pain, by the way, as well. We also showed higher levels of creatine to total creatine. And I'll talk to you a little bit more about what that might mean in a second. As well as, not surprisingly, higher levels of the inflammatory cytokine interleukin-6. But look at this. I'm going to circle these. The black line there is the mean, and then the circles are the actual individuals, all right? So for each one of these, there was really a subgroup that was driving the difference. Not everybody who was fatigued was different from the non-fatigued in particular. And when we put them in a model together, right, so adjusting for each other, we found that these three are independent predictors for fatigue. So that meant that if you had high IL-6, you did not have high creatine to total creatine or glutamate to glutamine. Each of these were different subgroups and explained fatigue or the association differently in these individuals. It wasn't that they had all three of these or even two of these. Most intriguing for us is that by far the strongest signal was creatine to total creatine ratio. And people ask us, they're like, oh, what does that have to do with fatigue, guys? I can understand maybe too much excitation in the brain could screw things up, but why this? So it turns out there's a whole field of science actually looking at mitochondria a lot, but also in the brain about fatigue and creatine to total creatine. So it turns out in highly metabolic organs like your heart and of course your brain that takes up 20% of your metabolic activity, right? You cannot store a lot of ATP, but you need it. So to be able to do that, you have to have a reservoir of phosphorus to take that phosphorus and put it on ADP and make ATP. And so you use phosphocreatine, and then you flip it over, and you make creatine, and you go back and forth in this nice cycle. When you have too much creatine, right, that doesn't have that phosphorus on it, you don't have that phosphorus to make ATP. Thus, you don't have the energy to actually do the things you need to do metabolically, right? So no brainer, no ATP, no energy, low fatigue. So let's go back to the Cygnus behavior model. We haven't yet asked the question, what was the correlation, the interrelation between the inflammatory cytokines and changes in the brain? So maybe you guessed from the model, there were no correlations between the IL-6 and the glutamate and the creatine, all right? They were all non-significant. Now, that doesn't mean that there might not be a subgroup that this is still a relevant model for, and this is in post-treatment realized, not during treatment, which I want to emphasize again, could well be a different model. So then I wanted to finish up this talk and say, well, how does acupressure impact and acupuncture mechanisms of fatigue? How might it actually cause a change? So we know a little bit about inflammation, but we actually wanted to take our two different acupressure treatments, and I'll remind you again here, we have a picture of the points, the red being the relaxation acupressure, and the black being the stimulating acupressure there, that showed the difference, the 70% versus the 35 to 40% there in mean reduction in fatigue. So we actually did a study where we gave fMRIs to 19 women at baseline and at 6 weeks when they had the end of their acupressure treatments. So they were doing this acupressure on themselves once a day for 6 weeks, okay? So what we found is in both arms had a significant decrease in fatigue severity, which we had hoped for and expected. And we then looked and saw, well, what was going on in changes in those brain neurotransmitters and in brain connectivity, all right? So I'm going to focus first on changes in connectivity. So once again, for all of you non-imagers and neuroscientists out there, connectivity is how the brain talks to different parts of itself. In other words, what are the networks in the brain, right? So this is very important. This isn't just about one static part. This is about the network of how we maybe perhaps think and have consciousness, right? So pretty important. And so what we had found is we put a seed, so a tiny little place in the posterior insula where we had found a lot of activity going on. And what we saw through time, so realize this is not necessarily, this is a correlation of change through time and how that signal is changing, how this network is changing, that these women actually had a greater connection, all right, or a lesser connection, I'll say a change in connection between the insula and an area of the brain called the dorsal lateral prefrontal cortex, which is also involved in cognition, and mental processing. So well could be involved in fatigue. But how did the acupressure treatments perhaps differ? So I'm showing this here. The black dots there, so those are individuals, the dots, show relaxation acupressure. The open dots show the stimulating acupressure. And what you'll see there is that connectivity increased between those two areas in stimulating. And even though it looks like it's kind of flat, it actually went down a little bit in the relaxation acupressure. This is despite the fact that both of these decreased fatigue. So then we went and said, all right, what about that glutamine that we had talked about and the creatine? And we actually said, is this mediated by any changes in these neurotransmitters? And what we found is that for the stimulating acupressure, the one that went down about the 35% or so in that range, it was associated with driving down the glutamate. You'll see GLX there, that's glutamate plus glutamine. So when glutamate went down through time, that was correlated with actually decreasing connectivity through time, all right? Now, take a deep breath. If you did relaxation, right, that actually drove down the creatine, thus having more phosphocreatine, more ATP through time. So as connectivity actually went down between those two areas of the brain, you actually saw a decrease of creatine and thus an increase potential for ATP to be made. So they changed connectivity through two distinct biological mechanisms based on what points the women did. So what are the implications for us as clinicians, as researchers? This is a fellow actually using a modern day, they called it a tricorder. If you remember Bones in Star Trek. Yeah, so he's putting it there. He had won a competition. It actually did vital things. So in the future, what we really want to be able to do is our patient, whether it be for research or for the clinic, we'd be able to actually get a baseline level and say, hey, this person has high glutamine, too much excitation, right? Or they maybe have high elevated creatine, i.e. low ATP, and would know, do we need the relaxation points or the stimulating points? And be able to actually tailor it and hopefully have a higher impact on reducing their fatigue and potentially other symptoms. And I think also as researchers, it might allow us to begin to say, you know, what are the mechanisms that drive this? And we can think into the future too, what are those mechanisms that might impact survival when we take a look at this as well? So in overall conclusions, obviously, we can't just look at one pot. Fatigue is many different pots. It has many different mechanisms. And we're really swimming out there. We don't know what this causes. I just want to let you know that even though we know that inflammatory markers are higher, except in certain treatment cases, nobody knows if changes in those inflammatory markers are even correlated with changes in fatigue. All right? And I know some people are doing that right now, and I'm looking forward to seeing that. And that we may be able to use acupuncture and acupuncture to specifically tailor and address these particular mechanisms. So of course, research takes a family, and it takes our lovely participants, and I wanted to put them all up here and thank them all, some of them of which are in this audience, and to thank our funders at the NIH and NCI. And I hope you enjoyed your caffeine beverage. And thank you so much for listening.